Hi, good afternoon, everyone. So, I, Priyanka from Janitri Innovations, welcome you all in this live webinar on fetal and maternal monitoring. So, Miss Mary from Haroon has joined from Kenya, and I will. So, Mary and Haroon is working as medical director at Limru Cottage Hospital, a Bachelor of Science in Nursing graduate with over 20 years of proven experience in medical, surgical, obstetrics, occupational health, travel health, and emergency nursing care. Having previously qualified as a registered nurse, she has been a practice manager with InterHealth Worldwide and international travel health facility based in UK with a regional offices Nairobi. Mary has a wide experience in managing health facility, having previously worked for major blue chip hospitals and non-governmental organizations locally and internationally. Have in previous jobs been awarded the Meritorious Award for Extraordinary Performance and scored the best in Africa and second best in world for proficiency and excellence in running the regional US Peace Corps health facility and formulating and executing best health practices in the region. Mary is currently providing management to entire nursing staff and also heads the entire clinical service in the Limru Cottage Hospital. So, Miss Mary, I welcome you with today in today's session, and you can start with the presentation.
Thank you, Priyanka. Thank you, and hello, everyone. Glad to be in this webinar. Thank you, Janitri team, Arun, and the entire Janitri team, and indeed Mr. Sharma for the invite, and to all who've taken the time to be present. Priyanka, thank you for that introduction. And I will go straight to our topic, which was really the importance of fetal and maternal monitoring, and particularly using the Janitri device.
Yes.
And probably just give a little bit of a story with Janitri and Limuru Cottage Hospital. So really it was, I must say, it was almost like a coincidental meeting where I was surfing on the net and I came across Janitri, and I was hoping that I could connect with someone there. And fortunately, I wrote an email and I got a response, and obviously they gave me a local connection. So that's how I came across Mr. Sharma. And for us at Limuru Cottage Hospital, just like you mentioned, we are located in the central part of Kenya. And probably just to give you a little bit of background, central Kenya is really in the highlands of Kenya, and it's a highly populated area. And just to give you a bit of statistics in terms of maternal mortality rate, we are quite high in terms of numbers. Our maternal mortality rate is about 350 deaths per 100,000 live births. That's in Kenya generally. And in terms of our infant mortality rates, that's we go to about 31 deaths per 1,000 live births. And that's a huge number and really underscores the importance of maternal and fetal monitoring.
Yes.
So in our facility at the Limuru Cottage Hospital, a lot of the monitoring is primarily done by the midwives. And as you would imagine, mainly we are looking at helping to detect any changes in both mothers, in the babies, advising early intervention that could be necessary, and also probably helping to avoid unnecessary treatment and probably even other decisions that can be made without proper monitoring. When I say that, I also want to talk about just some of the challenges and probably some of the issues that we face at the hospital, which would be probably very, very similar to many other parts of the world, particularly in the rural areas, rural settings. One of the things that we face is concerned or have to do with the high-risk mothers who come to see us, mothers who are probably hypertensive, who are diabetic, or who have developed gestational diabetes, mothers who have conditions like preeclampsia and eclampsia. Those are really common cases that we see in our facility and around the area that we operate in. We also have challenges in terms of mothers who would delay seeking treatment, either because of ignorance of available services, or even ignorance of maybe knowledge of what the danger signs are in pregnancy. And we also find that in the rural setup, there's also an element of poverty that can inhibit or can limit mothers in terms of trying to access care. So those are some of the challenges that we face. And I know that in many parts of the world, I'm sure, and probably in India, those are some of the issues that one would face. Now, we have also seen in the recent past postpartum eclampsia, which is a worrying trend, and which probably, if you have some of your janitary OBGYN teams on the webinar, maybe it's something that I would be interested to find out what exactly is happening on the ground on that end. But we have seen a bit of a surge in hypertensive cases of mothers who've just post-delivery a day or two or even 6 weeks. So that's also a challenge that we are facing. And again, I would go back to saying that it's really something that underscores the importance of maternal and fetal monitoring prenatally, intrapartum, and even postpartum. So those are some of the challenges that we have seen, and again, now talking about janitary and where the device comes in, I must say that, as I mentioned earlier, it was really a coincidental meeting and a good coincidence, because when we connected with Janitary India, they were able to actually connect us with a local agent or a local distributor, Mr. Sharma. And we started the journey, actually, I think, towards the end of 2021, I think, if I'm not wrong. And we talked about just the challenges we were facing. We talked about the device, and at that point, the device was actually in the process of being developed in India, and I was very keen and very interested in finding out what exactly that technology was going to look like. And so I think in April of 2022 is when we were able to receive our first 2 devices. And I must say that initially the devices were connected to a tablet. And by the time we received our devices, they had been tweaked a little bit. So the technology had been tweaked a little bit. And now we were able to use phones instead of the tablet, which for us was really good, because the phones were very easy to access. And a lot of the population, the nurses, the healthcare workers were very much used to the smartphone. So, just it was going to be very seamless to actually get into the technology without necessarily having to do a lot of adjustments. And so I must say that we really we were very excited about the device. It was received with a lot of excitement and anticipation, and training by Mr. Sharma and his team on the ground was actually very, very, very effective. So I must comment on the general ease of handling that gadget, which a lot of the nurses at that point had mainly used the CTG monitoring machine, which is quite is not as easy to move around with. It's not as mobile as what I would now term the janitary device. And so that was part of the excitement that was on the ground. The use, of course, of the phone, the attaching the phone to the device, and then it hangs on the mother, and then the antenatal mothers were able to walk around with it without hindering movement, was actually big, really big. It was an item that was really big. And I must say that the frequency as well and the recording of the data was something that was captured and very, very significant. The device was able to pick up data every few minutes, and and then after that we are able to record, we're able to print. The ability, of course, to share the information with doctors remotely. I think that was a big one, and I think for us that is really great, because the remote sharing of information was key in helping us to make decisive and quick decisions, so that our turnaround time in terms of making a decision was actually impacted on very, very greatly. So so I must say that the device has optimized this kind of monitoring, and at the facility we have adopted the policy of continuous monitoring for all our high-risk mothers. Like I mentioned, we have a significant number of high-risk mothers who come through our facility, mainly hypertension and gestational diabetes. A few of them will be also teenage pregnancies, who obviously fall under the category of high-risk mothers. So, so I must say that the device has optimized the monitoring and released our nurses. I would imagine, like in most of the medical or clinical setups in most parts of rural Africa and many other parts of the world, staffing is an issue. And so the fact that we were able to acquire a device that was going to help with continuous monitoring of a high-risk mother, as the nurses also take advantage of that situation to take care of the rest of the mothers on the floor, was something that we also thought was quite impactful on our facility. So the other bit that I mentioned also about liaising with the doctors remotely was actually also very significant, and our doctors have also taken that up very well. They are very grateful that they don't necessarily have to be on the ground, but they can monitor the patient along with us. And if we have questions, if we need to consult, then it is real time. So that was something that I really would commend Janitri and the entire team for actually coming up with something like that, because when care is real time, it makes a huge difference. And for us in rural Kenya, it's actually a matter of life and death.
Mm-hmm.
The fact that you can make a decision and turn around a mother who probably was going to have fetal distress, and make a decision to actually intervene and go for a cesarean section is really a matter of life and death. And for me, that's very, very critical, because of the numbers that I shared, the statistics that I shared about the mortality rate, our maternal mortality rate and infant mortality rate. Thankfully for us at the hospital, I must admit that the rate has not been very high. We've been in operation for the last probably 7 years or so. And we haven't had one maternal mortality, which I'm really grateful for. And as I look at the acquiring the device and seeing how that would also assist us in continuing to maintain that level of fetal and maternal monitoring, that really excites me, because I like the fact that we are able to give even our clinicians the confidence, and the fact that confidence is enhanced in the monitoring of the high risk mothers. As I mentioned, we have also been able to notice that we are able to make very quick decisions. We are able to coupled with, of course, the midwives' intuitive skills and knowledge, it has really enhanced the outcomes that we have seen in our facility. And for me, I think that is really a big one.
So, Mary, we would also like to know, like, at what stage during the pregnancy this fetal monitoring is important? At what point this should start, and for what should be the frequency of it?
Right. Now, in terms of monitoring, we talk about the prenatal stage, we talk about the intrapartum stage, and we also talk about the postnatal. But in terms of the prenatal stage, I think as soon as a mother has the knowledge that she's pregnant, I think it's really important that she comes into the antenatal clinics, where she's able to be advised on what kind of diet, what kind of things that she needs to do, what are the things that she needs to be looking out for, danger signs of pregnancy, what medication to avoid, what supplements to take, and just the general knowledge of what's happening to her, and particularly first-time mothers. I must say that that knowledge, sometimes it might be book knowledge, but when it is now practically applied on a mother who's pregnant, they're able to really connect with what the healthcare workers are talking about, and are able to be compliant with whatever advice they get. So prenatally, as early as possible, just making sure that a mother is aware she's pregnant. And for us as a country, we have a policy of the number of visits that a mother should at least have before coming in for delivery. And we recommend at least 5 antenatal visits. And of course, that comes with other testings, that antenatal profile, just to make sure that mother's hemoglobin levels are good, that knowing the HIV status of the mother, the hepatitis B status of the mother, taking up scans, which we recommend that at least 2 scans in the entire pregnancy period. So that is something that we look at, and so I would say that monitoring starts there. And when mothers come in and out, they're able to talk to the healthcare workers. They're able to tell them what they're feeling. Some mothers will come in and they have reduced fetal movements. You're able to pick it up from that point. And a device like the Janitri device is a really good device that has helped us to pick even some of these conditions. Like, for example, a mother walks in, she tells you she has reduced fetal movements, and you're thinking the most likely method of checking would be a scan. But with a Janitri device, you can quickly connect that to the mother and be able to pick up a fetal heart rate. And if that's a concern, then you can now escalate that to maybe going up to the level of scanning. Intrapartum, when the mother comes into the facility, admitted in the hospital, again, the monitoring is now even much more frequent. Again, depending on the level of risk. We as a policy, we recommend the electronic fetal monitoring using the Janitri device on all our mothers who are high-risk mothers. Of course, if a mother has no issue, pretty straightforward pregnancy, no major risks that are foreseen, then we can regularly just check, maybe do a Doppler, check with the PNADS fetal scopes. But when we have high-risk mothers, those that are maybe gestational diabetes, preeclampsia, teenage pregnancy, very young mothers, probably 15 years of age, those are the ones that we recommend that intrapartum, we are closely monitoring using the devices. And like I mentioned, after delivery, again, it's also an area that we have picked up. We have noticed that postpartum, within the next 48 hours or so for normal deliveries and 72 hours for cesarean section mothers, we are again monitoring to make sure that baby is fine, baby is feeding well, baby is not having any issues with lactation, mothers not having issues with lactation, the baby is able to latch, stuff like that we are looking out for. So it's a whole cross section of monitoring for our mothers.
Okay. So Mary, can you put some light on the healthcare system in Kenya? Is it somewhat similar to India, or how is it?
Healthcare in Kenya has I would say has really improved. The last couple of years, we are seeing less and less in terms of, particularly in the area that I'm interested in, maternal and infant mortality rates. We are starting to see ourselves closing the gap slowly by bringing in professionals, by training, improving on skills. But like I mentioned, the challenges, I must admit, are the same in terms of even, for example, just looking at the causes of mortality, maternal mortality in most of the areas, probably both in India and in Kenya. Many of the causes would be the same because, like, for example, we have the main causes for us would be hemorrhage, would be postpartum hemorrhage, would be eclampsia, would be infections. And I would imagine that those are some of this would be similar in terms of also healthcare in India. So I'm keen to also figure how what would be some of the challenges that the obs-gyn health workers are facing in India.
Yeah. So in India, we are also facing these similar issues where, like we talk about the 3 delays, there is sometimes delay in decision making. There's a delay in going to the facility. There
Right.
is right. So these delay does happen here in India as well, and can you put some light on the referral part, like how the referral is happening there, and the ambulances, how what facility they are taking care of, and number of home deliveries happening compared to the hospital deliveries?
So initially we had what we call traditional birth attendants, and these were trained people who would help with deliveries, home deliveries, especially in the very remote areas of the country. But I must say that in general, access to skilled professionals for antenatal, for deliveries would be, I would rate about it up to about 73% in Kenya. And then in terms of referral, what you're talking about, we have quite a good referral system where we have ambulances. The government has provided ambulances that can be used within the counties. So like if you have an emergency, you have an issue that requires referral to a higher facility, then it's easy to access ambulances and refer. I don't know what the situation is like in India in terms of referral. Do you have a challenge?
There's not much, I would say, challenge. I wanted to understand, like we have these rural hospitals, then from rural hospitals, the mother is referred to the taluk hospital, maybe the community health center, then from there to the district hospital. So this is the system which we are following, if from district hospital to medical colleges as well, bigger hospitals.
Right. Yeah, and I think it's probably similar to what we have here, because what we have is we have different level facilities, and sometimes, depending on the level of the facility, they are able to take care of maybe mothers who are going to have normal deliveries, and then if they have an issue, then they refer to the next level, who are able to assist in terms of maybe they're in a position to have a theater, and they can be able to take the mother for a cesarean section, for example. Of course, there are also other areas other situations where now a patient needs to be referred to a much higher facility, if maybe there are issues to do with that require maybe intensive care units or neonatal care units. So there is that system of reference and to escalate as per the different counties.
So, Mary, what would you say is the best indicator for the fetal well-being? Like what should be that particular parameter when we are monitoring a fetus, that if this is going normal, things will be normal? What is that first parameter we think of?
Say that again.
So what is the best indicator for the fetal well-being?
Yeah, right. So I guess for me the most important indicator for the fetal well-being would be really the fetal heart monitoring and just making sure that you're on top of what that looks like, that the fetal heart rate is maintaining, it's within the normal parameters, and of course if then it drops, then you're looking out for what would be the immediate causes of a difference or a variance in the fetal heart rate, and probably looking out for things like meconium stain, liquor, that would give an indication of fetal distress.
So what would you say is the most common cause for fetal distress?
I would say in my practice and in the facility, a lot of the times when we find fetal distress would be sometimes when maybe a mother had, maternal issues, let me say that. So like if a mother has preeclampsia, has hypertension, we find that, we might run into issues with fetal distress. Of course, there are also other fetal issues, like maybe a cord around the neck that probably was not picked up. That would also be an issue. There could also be infections, maternal infections that could give rise to fetal distress.
Okay. And what are some immediate services required for fetal monitoring that can be done even at home without any medical investigation or help?
At home probably is tricky, but one of the things that is useful is probably advise a mother on how to monitor their baby's kicks, and have like maybe a manual kick chart where every time they perceive a fetal kick, they record, and they probably can send that information. Now, of course, with the smartphones, you're able to connect with mothers even in the most rural environment. So you're able to talk on the phone, maybe advise on how to do that, and that would be one of the things that I would imagine would be used without medical intervention. And I don't know whether in India there are any other interventions that you can tell me that people use, without having to, that can be used at home without necessarily having the mother come to the hospital.
So I think for India, I think we are still exploring. There are people who are taking these fetal Dopplers at home. So
Right.
that is something people are exploring in India, as now everyone wants to have the devices at home. So that's there.
So are you saying that the mothers acquire the fetal Dopplers?
Yes. So now, like, it is easily available. So mothers are buying those fetal Dopplers just to listen to the heartbeat, and
Right.
so that's what we have noticed here.
Right. That's interesting. I mean, what would be the cost of a fetal Doppler
Um,
in
I,
India?
th- I think that's something we need to explore after the webinar. And
Right.
yeah. So there are a few more questions from the audience side, which we have taken previously. So they would like to understand that what are the challenges in Kenya and like how you are doing it different in your hospital.
Right. So mainly, like I said, the challenges are pretty similar to any rural setup.
Yeah.
Access, late access to services, ignorance of available services, maybe also, of course, issues to do with teenage pregnancies. So what currently we are doing in the facility, in our facility, is that we try and reach out, particularly just using like medical camps. We reach out to mothers in rural setups and do a lot of education, on danger signs of pregnancy. We reach out to different communities, using probably even churches, mosques, things like that, to reach out to the antenatal mothers in the community and just try and get them to learn about. So we do some kind of like mobile clinics and medical camps targeting women, targeting pregnant mothers. We carry out Lamaze classes to our antenatal mothers who come into the facility, just to teach them about labor, about what to expect, because we've realized that some of these interventions have impact greatly on the outcome. Just when the mother has a good knowledge of what's going on, what the danger signs are to look out for, she's probably more likely to be able to seek out help much earlier, and so reduce the numbers of delays in seeking treatment. And of course, the delays come with their own complications. So those are some of the things that we are doing as a facility.
So what are the facilities are available in the mobile clinics which you have talked about?
The mobile clinics are organized by our facility. So like it's not in conjunction with any other facility. And that's just something that the management of the facility has felt strongly the need to go out into the communities and talk about the issues that might impact on pregnant women and mothers, and therefore, have an impact in the reduction of the outcomes, the bad outcomes that we see. So it's more related to the management of the hospital, has nothing to do with other facilities around where we are. But we just go out, use our own resources, use our own staff, and just reach out to the different communities. Obviously, we look at the areas that are within our locale and within the county that we are operating in.
So next question is anesthesia interpretation to determine if the patient have to be taken for emergency C-section.
There are many factors that we look out for in terms of whether a mother needs emergency cesarean section. Of course, if we notice that a mother has come in probably with obstructed labor, and again, going back to the delay in seeking treatment, you find that some mothers will come to the facility at, maybe about 8 centimeters dilated already. And on examination, you find that probably the mother has some kind of cervical dystocia that needs now the attention of an emergency cesarean section. There are those who will be probably, an overt contracted pelvis that, no matter what happens, they cannot deliver normally and probably have not been attending clinic. So it's probably at the point when you come face to face with the mother that you're making that decision. Others, of course, will be cases of maternal emergencies that need emergency intervention, things like prolapsed, cord prolapse and placenta abruptions and previas, stuff like that is what will make us run to theater.
Okay. Next question is it normal for a baby heart rate to drop during the pregnancy?
Yes, it can happen. It happens during pregnancy and probably even during labor. So the baby's heart rate is the normal heart rate would be around 100 and probably 30 to 150. I would give that range, and maybe anything above 160 beats per minute on a fetal heart rate would be considered high. A fetal heart rate of less than 110 would be considered low, and there would be causes that would cause a fetal heart rate to go low. Of course, when the fetal heart rate has gone low, then it means that there is some intervention that needs to be done. But again, it like I said, the fetal heart rate varies at any one given time, just like our own heart rates in adults or in people who are the general population. You'll find our heart rates can range from 72 to 95, and when you're running, it can go all the way up to 120 or something like that. So yes, it's possible that the fetal heart rate can drop, but in instances where it has dropped and noticed to have dropped, then would be a good idea to be in the hospital where maybe a scan is done to identify the reason for the drop in fetal heart rate.
What could be the cause of intrauterine growth restriction of fetus in uncontrolled pre-existing diabetes mellitus?
Uncontrolled diabetes can lead to definitely reduced growth in the fetus because one, there would be what we call placental insufficiency, and if we see that, then the likelihood of a baby born from a mother who has pre-existing diabetes can have that kind of outcome. So again, we also have seen a number of cases where there's gestational diabetes and the babies born out of these conditions have generally very big weights, macrosomia, so to speak. But again, that's also not a healthy condition, because sometimes those babies also have low blood sugars and require much more in terms of monitoring once they are born. So again, going back to just making sure that mothers who are diabetic are on treatment, are on high risk clinic, they are being monitored very closely, their weights are monitored very closely, their sugars are monitored very closely, just to ensure that the outcome is not bad, because some of the outcomes can actually lead to intrauterine death for mothers, especially with diabetes.
And the next question is, what are the protocols of midwifery practices in labor and birth room? So I think this will be a little detailed one because, during the intrapartum, different guides are followed, different protocols are followed in active and latent phase, then different protocols for those phases as well. So that is something that is asked.
Yeah, well, we as a country, we have the national guidelines that guide the protocols for labor, for monitoring of mothers in labor, for intrapartum, in the delivery. I mean, it's a huge, probably there's lots of information, but what probably I could say at this point is that we have a very comprehensive guidelines and protocols set by the Ministry of Health that guides our midwives, our nurses on just how to take care of a pregnant mother, all the way from antenatal to the intrapartum period and postnatal. Very, very exhaustive in terms of just what the investigations are, what monitoring should be done, what medications in terms of supplements. All of that is very, very well documented in the guidelines, and of course the qualifications of the midwives is also something that is outlined, and just what level and skill and proficiency the midwives are able to operate within their scope of practice, of course, and dealing with whatever issues that they can deal with, and of course escalating, consulting, and engaging with the obstetricians, gynecologists, pediatricians, and whoever else needs to come on board whenever it's necessary. So it's really a huge document, almost like 600 pages. Yeah.
Oh, yes, that's gonna be a big one. So,
Yeah.
you in your facility, you are following partograph as well?
Oh yes, definitely. We use the partograph to record once, of course, the mother has gone into active labor, which is at 4 centimeters. Then we start using the partograph. And the beauty of the device that we have been using is that it's able to chart out the partograph, which is really good. So we definitely use the partograph, and it's part and parcel of the recommended guidelines when mother is in active phase of labor.
And so you have talked about fetoscope, that fetoscope you are using previously, and say CTG machines as well. And any other invasive method that is being used?
No, apart from the fetoscope and the Dopplers, there's no other invasive method that we use. And of course, now currently, of course, we have incorporated the Janitri device, but there's no other method that we use in terms of monitoring. The CTG has been a common one, but like I said, the issue with the CTG is just the mobility. So, the need to move around with it, it sort of ties the patient onto the bed, and so they're not able to walk around. So so not as user friendly as the mobile device that we're currently using.
Okay, so yeah, I think that's all the question we had from the audience side as well. So
Right.
any other thing you would like to highlight or would like to point to, how we can make this monitoring better? Like
I was just Yeah, I was thinking about the device and just probably trying to see how we can reduce the consumable part of it, because that gets expensive. So, like, the little patches that have to be used, maybe, I don't know how, just relooking at how we can probably reduce that so that it's not as expensive as and can be widely used in probably setups that may not necessarily have the resources. But that's one area that I was thinking about, just as a recommendation. And also probably we talked about the manual system of checking kick charts and how to check whether baby's condition is good. And I know you mentioned about the Dopplers, and I know that there was a mention of a watch that a mother can sort of put on her wrist and walk around with it and transmit the results on remotely.
Yes.
I think that would be interesting to explore.
Okay, great. Great, Mary. I think it was a great session we had. We did get to know about a lot of things that are happening there, and what we are doing in India.
Right.
Yeah. So, yeah, thank you
Yeah.
so much for joining this session. Thank you, everyone.
Thank you, Priyanka, and everyone else.
Yeah.
Good luck to you.